Welcome everybody in the Zoom audience. I'm Terry Maggedy, Chair of the Elder Law Committee of the Beverly Hills Bar Trust and Estate Section. And this program is being sponsored by the Healthcare Law Committee, Health Law Committee and the Elder Law Committee jointly. And the first thing I do, right before I just turn the program over to our co-chair, Carol Scott, is I'd like to thank our sponsor, the Sanborn team and Nancy Sanborn. They are real estate brokers who deal in areas that focus on real estate related to our subject matter for the Elder Law Committee, and that is real estate relating to probates, real estate relating to trust, real estate relating to older people. And thank you, Nancy Sanborn and the Sanborn team, for being our sponsor for many, many years now. And really, the person who's responsible for having our wonderful guest here, Dr. Wasserman, who you're going to hear about shortly, the person responsible for this is Carol Scott, who's the chairperson of the Health Law Committee. And so I'm going to turn the program over to Carol and let her introduce our program and our speaker.
Great. Thank you, Terry. I want to thank Carrie, I want to thank you and your members and the Sanborn team for co-chairing with us today. I think this is really one of the most exciting seminars, webinars that the bar has had, because we have someone who is on the cutting edge of the pandemic epidemic. And while we're all very stressed out and the numbers are going up as businesses are opening, I think you'll find that his message is a promising one, and he won't just be citing statistics. Let me tell you a little bit about Dr. Wasserman, and if I leave out any of his background, it's because I want to give him more time to speak. Dr. Wasserman is a physician. He's a gerontologist. He is familiar with the assisted living and board and care and nursing home situation in California. He is the Chief Executive Officer he is the president of the California Association of Long-Term Care Medicine, which is a unique organization in California. He is the medical director of Eisenberg Village of the Jewish Homes for the Aging. He has been on the front line in the battle against COVID and the containment against COVID. He previously served as the chief executive officer for the largest nursing home chain in California. Prior to that, he was the executive director of Care Continuum, the quality improvement organization in California. And those of you who practice healthcare law know how important that organization is and those types of organizations are. In 2001, he co-founded Senior Care of Colorado, which became the largest privately owned private care geriatric practice in the country. And in the 1990s, he was the president and chief medical officer for GeriMed of California, where he assisted in developing GeriMed's clinical pathways. And I'm going to turn it over to him to provide some important insights. And one thing I want to point out to people, and I hope he'll talk about, is the guidelines that he's been working on, the insights that he has and he's developed, and the importance of testing, which I found very enlightening, particularly in light of the president's statements yesterday that we shouldn't be doing testing because all we'll do is find out more people are sick. So Dr. Wasserman, let me turn the program over to you. Before I do though, if anyone has a question, hit the buttons at the bottom that say Q&A, and Dr. Wasserman says he will take questions as we go along, as well as questions at the end. But please feel free to ask questions because this is really an important topic. Thank you.
Thank you, Carol. I really have been looking forward to this opportunity. Excuse me, I was outside and I came in and my wife's taking a nap, so I couldn't put on a shirt to look a little bit better. But and I really do welcome questions and such. Carol's correct. My background has put me in a unique position with this pandemic. I am a geriatrician. I've cared for frail older adults for over 30 years. I ran the quality improvement organization, but I've also run literally $1 billion nursing home chain. And so I have a deep understanding of the industry that literally on February 29th, when I heard that COVID was in a nursing home in Washington State, I knew what was going to happen. And honestly, I then began reaching out to many of my colleagues on the front lines. And for much of the last 3.5 months, I've been their voice. I was sort of semi-retired at the time, so I've had the opportunity to speak for a lot of my colleagues who've been dealing with COVID in nursing homes. And Carol said I was going to say some positive things, and I think the most positive thing I can tell you is the industry and the government want to make it sound like there's nothing you can do about this virus, and that is just not true. Actually, back in April, my organization put out what we call our long-term care quadruple aim for COVID-19 response. And it basically lays out what nursing homes and similarly assisted living facilities and group homes need to do to protect residents of these facilities. And before going into that, I will point out that on a certain level, the fact that the first place to get hit by COVID in the United States was a nursing home was actually really fortuitous. It literally scared the daylights out of nursing homes and assisted living facilities and older adults in those settings. And many of them actually locked down on their own in March. Look, I told my parents who are 86 and 82 around March 10th to stay at home and not go out. And so, you know, I think a lot of older adults have known what to do. I think older adults, retired, have been able to stay at home. And I think that's protected and saved a lot of lives. In nursing homes and assisted livings, it's a lot more problematic, and for obvious reasons. And so the four elements of our quadruple aim, in number one, and I think from a hierarchical perspective, this is important, is personal protective equipment. And so PPE, if nursing home staff and assisted living staff are not using personal protective equipment, take this off, then the virus is going to win. Let's just put it that way. Without masks, without the other personal protective equipment, this virus will win despite all other efforts. And so there's been some literature that came out recently that says it doesn't matter whether you're a 1-star facility or a 5-star facility, that the virus is going to get you. That's true if you don't have PPE. So I don't care if you're the best facility in the country or the worst facility in the country, if you don't have masks and gloves and personal protective equipment, this virus will win. The second part of but on the other hand, if you do have personal protective equipment, you can make a big difference, and that's key. And that then goes to the second item in our quadruple aim, which is testing. And I actually shared yesterday with Congress that the CDC knew in March that asymptomatic carriers could transmit this virus in nursing homes. They published that information. Anyone who paid attention to the literature, any experts in geriatrics and long-term care medicine knew by the end of March that asymptomatic carriers could bring the virus into nursing homes and assisted living facilities. And so the second part of our quadruple aim is testing. Because if you test and you know that people have the virus, you can send them home. Similarly, you can test your residents. If you know that someone's got the virus, you can put them in isolation. And so testing is a very, very important part of protecting these frail older adults. The third item, goes without saying, is infection control. Hand washing, doing all the right things, and actually knowing how to use masks. I do my once a week trip to the supermarket in my N95 mask, and I go with the senior hour, and I still find grocery store employees walking around without masks or wearing a mask below their nose. So using the personal protective equipment properly really matters. And then the fourth item of our quadruple aim is emergency preparedness, which is really a proxy for good leadership. And in the nursing home industry, I believe that one of the key elements of success for quality, regardless of COVID or anything else, is good leadership and management skills. And there is no better time to test a leader and manager than during a crisis and a pandemic like the one we have. And so those are really the four elements of the quadruple aim. And I believe that if you've got PPE, you're doing testing, you're doing good infection control, and you've got good crisis management, people don't have to die. And you can do a pretty good job at holding off this virus. Now, is it 100%? No, for a lot of reasons. Unless you're testing every day, which we can't do, it doesn't make a lot of sense. We know that someone can get the virus, be asymptomatic, and so if you're testing once a week, there is a chance that someone's going to bring the virus into the facility. If everyone's wearing gloves and doing great hand washing, the likelihood of transmission is dramatically reduced. One of the reasons, though, you need to test is if people have the virus and they're asymptomatic and they don't know it, they're going to be more likely to not do great hand washing, not use their mask. So in the case that you've got someone who's got the virus, that you've got them working with COVID patients, for example, because they know they have the virus, they're going to pay more attention to being careful. I think the fact that we're testing folks lets folks know that we're going to know if they're positive as well, and it just heightens awareness. So really those are the key components. And to Carol's point, this virus doesn't have to have a 30% mortality in a nursing home. And not everyone in a nursing home or assisted living facility has to get it. I think we're learning every day that if people wear masks, you can reduce the spread of the virus. So, I think, those are sort of the basic components. It's actually not that complicated. So that's sort of my opening on this. I think from a legal perspective, I've been absolutely intrigued on a few fronts. And that is, so the experts have known what I've just said since the end of March. Testing wasn't readily available. PPE wasn't readily available for a lot of complex reasons. And unfortunately, both the Centers for Medicare and Medicaid and the CDC were giving inadequate advice. And even to this day, their advice isn't great. And so you've got everyone basically saying, well, we're following CDC guidance. What does that mean? It kind of goes back as a physician. It's like saying, is something FDA approved or not? Well, as a practicing clinician, if I practice based on the FDA, I never have. Okay, I practice as a clinician using my knowledge and expertise, as well as, I guess, from a legal perspective, looking at the standard of care as it relates to what my colleagues do and what we think is appropriate. And I think this is where, there are plenty of my colleagues who have known the right thing to do with COVID since the beginning of the pandemic. And I think when we look back, we're going to find that there are places that instituted protocols and did the right things based on that knowledge. And there were others who wanted to but couldn't due to supply chain dynamics and availability. And then there were others who knew the right thing to do, but had others keep them from doing it. And I think there's a lot of interesting questions that are going to be asked in the coming months and years. And that's the other comment I'll make. The numbers you're seeing right now, 120,000 deaths from COVID, those numbers are absolutely underreported. The numbers of deaths in nursing homes at 50,000 are absolutely underreported. CMS, I told you I was going to be positive, but this is just the truth.
That was one of my questions is, CMS, are they underreporting? Is the reporting public now?
So there's two issues around that, and that is, from the beginning, we've known that before the first cases are reported in a facility, especially if there's no testing, there's generally an increase in deaths. So this happened at Kirkland. They literally had double the mortality in their facility in the few weeks before they had their first COVID case. So, and then for the next month or two, we didn't have adequate testing in nursing homes. And we actually haven't had adequate testing. I mean, there are still states around the country that don't do adequate testing in nursing homes. So you have people dying without being tested who aren't necessarily being diagnosed with COVID. And one of the things we know about COVID in nursing home residents is atypical is typical. So nursing home residents will die from COVID without having a fever or cough, without having obvious COVID symptoms that would normally occur in younger adults. So what's ultimately going to happen in the next 6 months to a year is the epidemiologists are going to look at the total number of deaths. And they're going to compare those number of deaths with normal number of deaths. And we've already seen reports from the Washington Post and the New York Times that excess deaths are already in the tens of thousands around the country. And, I think, I honestly think the number of people who will die from COVID will easily reach 250,000. And a large percentage of that, probably bordering on 70%, will have come from senior housing, whether it be nursing homes, assisted livings, group homes, retirement communities. And at the same time, I think a lot of older adults who are ambulatory and live alone are best served at staying at home. So
I remember you had said initially that, I don't remember who was in the paper and in an interview, that you would tell someone if they could either to stay home or leave a facility, but we're not all prepared to take care of people, especially if they're sick.
Yeah, that was interesting. I was asked by an LA Times reporter when the director of public health for LA County said, if you've got a loved one in a nursing home, take them out, which, I actually had a reporter ask me recently about the competency of the director of public health. And I have to just tell you, for a director of public health to say something like that is not really, no, I'm not gonna put a word to that.
Okay.
Here's the deal. Most everyone who lives in a nursing home is there for a reason. They're there because they're frail. They're there because they need help. I always tell people, and I've been doing this for 30 years, to approximate what even a poor nursing home does for a frail older adult could easily cost a family $20,000 a month. Okay, so, if you have a loved one in a nursing home, you need the wherewithal, you need the family, you need the money to bring a loved one home. Would I do it? Absolutely. If I had a loved one in most nursing homes, I would have brought him home. At the same time, most families aren't prepared to do PPE and strict hand hygiene and everything else and do all the infection control. So, it's actually a real challenge. So I think the vast majority of folks in nursing homes, they're best being there. And so the question kind of just came up, what about I had a parent in an assisted living facility? Same thing. Now, again, depends on the one you're at. If that assisted living facility is doing everything right, what does that mean? It means they're monitoring their staff. It means that every staff person is wearing a mask. It means they're wiping down commonly used surfaces every 3 to 4 hours. If they're doing all that and they're testing staff on a regular basis, chances are that those facilities have done a good job. And a lot of facilities have been doing this. And I think, would I still bring a parent home? Maybe. I mean, just because for me, I know what I'm doing. I know that I'm isolating. I know that I'm doing all the right things, so I trust myself. So that said, I'd be able to do that. But I think most people would really struggle with doing that. And if you bring a loved one home and you don't have the ability to care for them, and if you're going in and out and going to work and potentially bringing the virus in, you've got to start thinking, am I going to wear a mask at home? Things like that. So it gets kind of complicated.
Let me ask you two questions, because they tie into what you're talking about. First is there's been an issue with not allowing caregivers or families in a facility. Residents can't communicate. How do we know? How does a family know the same things, the question you were just asked, or you're answering about wiping things down and wearing masks? How do we monitor that? And how can lawyers and fiduciaries and families and the public make a difference? What can we do to make sure these places are safer if we have
so
people are dying?
On the nursing home front, this has been a challenge because the ombudsman have been kept out of facilities, which I have an issue with. The surveyors can be problematic. So what I've been telling folks is you got to be the squeaky wheel. You've got to be asking the administrator, the director of nursing, what are you doing? Are all your staff wearing masks? Do you have adequate PPE? What are your infection? Is your infection preventionist working full time, doing their job? Which is something we recommended on March 13th to the California Department of Public Health, which actually is now being required of nursing homes.
Repeat that again.
So every nursing home in the country has an infection preventionist designated. But almost every nursing home in the country, that person has 6 other jobs. And so our recommendation on March 13th to the California Department of Public Health and subsequently to CMS was require every nursing home to make that person full-time so that the only job they have is infection prevention and infection control. And I actually wrote an article back in March on literally that person is your infection prevention general in a facility. So I think pushing your facility to say what type of infection prevention, do you have a full-time person? Now, assisted livings don't have this type of person. So the question is, how are they getting and providing infection prevention expertise? And I think that's a good question to ask them. What are you doing in terms of that? Do they have PPE? And what are their housekeeping people doing? And how are they monitoring staff? Because the number one thing about this virus, first of all, is no one who's sick should be coming to work, period. But since people who are asymptomatic can bring the virus in, that's where you ultimately need regular testing of staff to make sure that you don't have staff bringing the virus into the facility. So I think it's fine for families, not only fine, but I highly recommend families to just be squeaky wheels about those issues. The nice thing is it's pretty straightforward. Strict hand washing, wearing masks, and testing. It's not rocket science. And I think those are things that you could hold the feet to the fire.
I was going to tell you there are 2 more questions. And also, when you have shared bedrooms, for residents, is the mask and infection control enough. But why don't you answer the questions that have just been posed?
So I'm going to answer the second question here about if you go out for a walk outdoors, you wear a mask. I go for walks every day. I live in a neighborhood where I know that if there's other people walking, I can be more than 6 feet away from them. Okay, so usually 20 to 30 feet away from them. Fortunately, I don't have a lot of cross through in my neighborhood or where I go for runs. So I don't wear a mask when I'm outside running or walking. But if I go to the supermarket, I wear a mask. If I go anywhere where I think people may walk by me, I would be wearing a mask. So absolutely. Now, the other question is a real big one. And I spent a lot of time in the last 3 months focused on getting.
Why don't we summarize the question? I think the question basically is, how do you enforce the recommendations? If you want to be the squeaky wheel and you find out the facility isn't doing what they're supposed to be doing, what are your options?
Wow.
And we know we're not even talking from a legal point of view, we're talking from a practical point of view.
Well, I hate to say this. I actually have, someone found me because I'm all over social media and everything else, and they were trying to FaceTime with their mother, and we ended up on KTLA News. And she wasn't able to FaceTime because there was a family squabble and the brother had power of attorney, and all she wanted to do was FaceTime her mom. And I ultimately told her, get a lawyer. Now that said, you can engage the health department. So I think the other thing to do is also be noisy with both the county and state health departments where you have concerns. Now, assisted livings are not under the health department. They're under the Department of Health Services, or I always get confused.
Department of Social Services.
Department of Social Services, thank you.
And I don't think there's anything wrong with getting a lawyer, but what can you do before that?
No, the problem, I hate to say it is, I think our government systems have failed us. And we're seeing it in COVID. I think the health departments have failed us at both the federal, the state, and the county levels. And I wish I had a better answer for you. I find it ironic that my ultimate answer is get a lawyer. But I think, well, actually, the other is call a reporter.
I think one thing we can do, and I can do it afterwards, and with Terry and I, is we can list all the different departments, what they regulate, who to call, and phone numbers and emails for social services and for the Department of Health Services. And maybe, I didn't mean to interrupt you, but maybe the more people calling and bugging them, the more they'll be responsive. And I mean, you said you had a call yesterday with Congress. I mean, is that the way to go?
So I think it's all of the above. I've been in this field for over 30 years. There are a lot of problems with the nursing home industry, with the assisted living industry. There's a lot of ageism in our society. And if there's one positive from COVID, it is shining a light on the weaknesses in the systems. And I will say, between the media and the government, I, for one, have personally utilized the leveraging of those areas to get attention. So I actually think there's something to be said for calling a reporter and letting them know what's going on. I want to go back to a comment about solitary confinement. And I've been so focused on protecting older adults. Some of my colleagues have really been pushing the issue of the fact that we've created prisons in nursing homes and assisted living facilities, and they are correct. And I've actually shifted my focus in the last couple of weeks. We just put together an expert panel. We actually had to put together an expert panel on testing, and we published a paper a few weeks ago that I think helped drive guidance around the country on testing. We are putting together a similar expert panel as it relates to isolation and ageism, and the fact that we're talking about, opening up for the rest of society, but we're going to take care of grandma and grandpa in their nursing homes by keeping them locked up. That the word for that in medical ethics talk is infantilization, and it's ageist. And while there's a real fine balance between protecting and infantilizing. And I think it's time for the experts to fully engage on this. And I think the irony, and I'll be political here for a minute, is from the federal government down to the state and county governments, for the first 2 to 3 months, they literally ignored frail older adults. And now that they're suddenly realized that a bunch of them have died and that it's dangerous, they're going to protection mode. But they really need to think about how they can help the quality of life of older adults. And so it shouldn't just be about, it needs to be about protection, but it should be around protection within the context of providing quality of life. So why do we have to assume that we have to keep grandma locked down in her nursing home versus developing systems and programs and processes to allow families to come visit, whether they visit outside, whether they visit through plexiglass, whether they visit, and I've seen some really creative plastic barriers made where you can hug, whether families get tested with point of service testing. So you go in and you get tested, and 10 minutes later, you don't have the virus, and you still wear a mask, and you do all the right things. There are ways of doing this rather than taking the easy way out of saying, let's just put grandma in prison in her nursing home and assisted living, because that's the easiest thing for us to do, while we're worrying about letting all the younger people go out to do whatever they want to do. And I think it's a real problem for society.
We talked for a few minutes just about the concept of social isolation and the elderly. My understanding is it's even more, not even the prison concept, but it's even more significant that elder adults be engaged to keep their mental facilities.
Oh, yeah. That is absolutely critical. And one way or the other, and there's a number of folks at the LA Jewish Home, we've been working with, using iPads and things like that to have residents interact with family members or others. I think I'm involved. I'm on the board of a charity called the Wish of a Lifetime Foundation. We grant wishes to seniors, and we've developed some programs again of bringing interaction into nursing facilities and assisted living facilities. I think this is a great opportunity with folks at home. Everyone, people are at home, they're not working, or they're working from home, or for kids who aren't in school, who are at home. There are great opportunities to use Zoom platforms and other platforms to interact with older adults. I think there's just a myriad. One of the reasons I became a geriatrician was when I was a kid, I just loved sitting around with all the older adults. And, over my career, I had met some incredible people who have been part of history. Okay. I had a dear patient who became a friend, who came face to face with Joseph Mengele 3 times and survived. I had a patient once who was in the plane that took a picture of the Enola Gay dropping the bomb on Hiroshima. I actually have a neighbor across the street who's 95, who was in one of the last major air battles in Korea. And these folks have stories, and they love to share it. And their stories are incredible. And, I've been blessed over the years of being able to hear the stories from my patients. But why couldn't, kids, instead of sitting at home playing video games right now, be on a Zoom call with folks who have lived through history? So I think there is a lot of incredible opportunities out there for us to do stuff like this. And
yeah, I think one of the, something
need to
just
focus
popped.
on that.
where it froze. I think one of the sad things is we're losing a generation that lived through the Holocaust, lived through World War II, and unless they're recorded and videoed, I mean, this is the last opportunity. You know, I wanted to interrupt for 1 minute, but then have you talk about assisted living versus nursing homes. But one of the participants, Betty Norwin, shared some information that California Advocates for Nursing Home Reform, who will also be on our resource list, that you can contact them for help. They're starting a social media campaign this week that's hashtag Visitation Saves Lives for anyone interested. They want stories about social isolation. I think it's also your point about reporters. Reporters are looking for good stories.
No, they are. And, you know, on the face mask question, because the state mandates face masks indoors and anywhere you're going to come in close contact with people. So if you're out somewhere where you're not around people, you don't have to wear a face mask. But if you're going to come in contact, if you're going to come within 6 feet of someone you don't know, you should be wearing a face mask. That's the simple answer to that question. The other question that came up was regulation of assisted living facilities. And here's the bottom line. Assisted living facilities are glorified apartments. Many of these companies sell themselves as places that provide health and well-being for their residents. And I think COVID is going to shine yet another light on the fact that that's a lot of marketing. And the industry is going to have to make a decision. Does it want to be health and well-being, or does it want to be housing? And because of that, I think the regulations are much more limited in assisted living facilities. So, yeah.
So I have a question as a lawyer who works with regulators and does regulatory work. Where is the county? Where is the state? You talked about that quadruple plan. Is that just something that's being suggested by a group of physicians who agree with each other? Or, I mean, what's the state mandating? What are the requirements? Give us the bottom line. And what do you think should be changed in terms of regulation and legislation?
So on a positive note, what's been frustrating to me is I'm a clinician. You know, when I see a problem, I want to fix it. My organization made a number of recommendations to the California Department of Public Health in March and April. I would have liked to have seen those recommendations implemented in March and April. Most of them have been implemented as of now. So the things that we mention in our quadruple aim have basically been required by the California Department of Public Health in a facility, a nursing home's mitigation plan. Now, you know, I just listened to congressional testimony today, and the head of the CDC says, well, they're encouraging nursing homes to do the right things. I'm dumbfounded. Encouraging is not the word you use during a pandemic. When the efforts you're making, with the recommendations you're making, will save lives. So encouraging, to me, doesn't cut it. And so I do believe that a lot of these things should be mandated or should have greater teeth, should be done in more real time, and should have more consequences attached to them. But on a positive note, again, here in California, the recommendations that are made by the California Department of Public Health are falling pretty closely in line with the recommendations we've made. And in a normal world, getting the California Department of Public Health to implement things we recommend in like 2 to 3 months would be amazing. Unfortunately, you know, if these things had been implemented 2-3 months ago, thousands of people would not have died.
So maybe we can post both the recommendations and what the department has done so that families, again, fiduciaries, people who act as ombudsman can see what they should be asking for. I think Chris Wilson just raised a question about reimbursement, which also goes to the article on dumping patients.
So if you saw the article in Sunday's New York Times, I've been worried about that happening since the first week of March.
Well, let's go back just 1 minute. Is there special reimbursement for COVID? I mean, how does that?
So there's a few issues around reimbursement. So reimbursement is a complex issue. Medicaid reimbursement is generally inadequate. I think most everyone agrees with that. Though it is a little more complex than it would appear, but it's generally inadequate. Under the new reimbursement system that Medicare has, called PDPM, the patient-driven payment model, that went into effect back in October, higher acuity patients pay more to a facility. And on top of that, different states have, added different payments. There was this thing that was around about a month and a half ago that California was going to pay assisted living facilities like $1,000 a day to take COVID patients. I hope that's kind of disappeared. There was a lot of pushback. I know Canner was pushing back on that. I sent letters and emails and texts and phone calls because it made no sense to me. But there's a bit of a catch-22. Taking care of folks with COVID cannot cost the same as taking care of people without COVID. And so how we as a society address this is a very complex question. My concern is you can't just throw money at this problem. Because if you throw money, so the federal government is throwing money at COVID and nursing homes and such. And my recommendations to Congress has been follow the money. How much of that money is actually going to direct patient care? How much of that money is going to the frontline staff who are caring for the residents? How much of that money is going to provide for PPE and testing at fair market value? Okay. Versus how much of that money is going to PPE that is bought from related parties at higher rates of reimbursement. There's a lot of stuff to unpack around the industry that COVID. I alluded to the fact I ran a large nursing home chain. And if you read the New York Times article, it's the first time in print that that was mentioned that I may have left on not so comfortable terms. And there's a lot of issues in the senior housing industry. There have been for years. Many of you are probably aware of them. Most people don't care. Most media people, reporters, journalists don't care. The only folks who generally care are the family members and the attorneys. COVID is going to change all that. And here's how and why. If the government and the industry had actually accepted this virus and acted on it and began reporting the deaths accurately from the beginning, we would know that there's about 100,000 deaths right now in nursing homes and assisted living facilities. That's the number I'd probably peg it at. And that would be big news. And it would make the news cycle. And then we'd move on to something else. Instead, the government kept it quiet, the industry kept it quiet, and the numbers are going to come out over the next several months and the next year. And I've been getting calls from both plaintiff and defense attorneys. We got someone calling us about this. How does this fit in? What does this mean? And I'll give you an example of something that I've been struggling with since March. I've had colleagues call me and say, I wanted to test for COVID and my facility wouldn't let me. Okay. And I said, would you go public? Would you talk to a reporter? No, I don't want to rock the boat. but they all call me. Right? So I get to not sleep at night. I get to call the reporters. But here's what's going to happen. Once all the news comes out and the families start asking questions and they start saying, you know what, how come mom wasn't tested? How come the staff wasn't tested? And then there's going to be some staff people who lose their job or decide they need to say something. And before you know it, some people are going to get deposed. And these stories are going to be coming out in the coming year. And through all that, this industry cannot hide from COVID. COVID will ultimately be the great unmasker of all the challenges that the nursing home and assisted living industry faces. And I hope that that's good. I hope that that forces us as a society to look at the nursing home industry and the assisted living industry and ask ourselves what we want for our loved ones and how we want these things to work and operate and what kind of transparency we need from it.
Now, I want to go back to the rate issue. I know you said you can't throw money at the situation, but I mean, you're at a facility, you know the budget, you've worked at facilities. I mean, are the rate of Medi-Cal, are nursing homes able to provide quality care, get PPE, get adequate staff? I know staff paid very little, and have the staff ratios at the rate they're being paid.
No, there's actually no way under Medi-Cal reimbursement to deal with COVID. No, the answer is no. You need to provide the PPE, to provide the testing, to provide the staffing and resources and such. No, Medi-Cal, the existing Medicaid, Medi-Cal rates cannot cut it.
So has that been part of the recommendations of the task force and talking to the state and also to the feds to the extent that there's a federal share?
So this is what's interesting. As a clinician, my focus has been on how do we protect and serve the health and well-being of older adults. I have no doubt that the industry is going to ask for more money, and they should. At the same time, I think there needs to be accountability for that money. So I think, and unfortunately, being a clinician who worked on the business side of the industry, I am all too aware of how putting money into the industry doesn't necessarily end up delivering care. So I think this is a great opportunity to say, okay, we're giving more money to provide for the PPE, to provide for the testing, to provide for additional staff or resources, but let's make sure that the money is being spent on those things. I actually had an interesting idea that I recommended in my testimony before the State Assembly, and that was for the next 6 months, nursing homes in California should not have to pay rent, nor should they have to pay their liability insurance. Okay?
But you have private individuals who are landlords and insurance companies who are going to scream. Who's going to make
happening? It's the rest of the real estate industry. So why exempt nursing homes, right?
So actually, it's interesting because it goes to a much broader societal issue, and I'm a business person too, and I actually own rental properties. I would be okay. I think the interesting thing about my proposal is the real estate industry behind senior housing, they're doing just fine. Not only are they doing just fine, they now are able to borrow against their assets at ridiculously low interest rates, okay, which I'm sure they're doing. It is a fascinating question that why not let the real estate industry behind senior housing take the brunt of the financial impact of this virus. And similarly, I say the same for the insurance industry and on the liability side. Look, both the real estate industry and the insurance industry managed to not only get by unscathed, but got protected during the 2008 meltdown. I don't think they should get a second shot at that. I personally think, and I have to tell you, again, not to be political, but we're in a blue state. I actually think there could be an appetite for this recommendation. Yeah,
it's an interesting recommendation. I don't know, Terry, do you have any questions or responses or any thoughts or?
So interesting. Public policy thoughts, but I don't think we want to go there. But it's
Okay.
it's very interesting. I'm just digesting this.
Well, and I'll tell you.
Oh, I just want to ask Terry, do you have any questions coming from the Elder Law Committee for
Look, a major theme has always been, older people, families, I'd like to keep mom and dad, aunt, uncle, myself at home. That's always been a major theme. So as with just about every other thing that COVID touched, in any industry, retail, just pick any industry, all it's done is it's like accelerated something that was already there. Like, who would want a parent or a loved one or yourself in assisted living or skilled nursing? I mean, people were already fearful of that. People already wanted to stay at home. And of course, but you've got the flip side of it. It's equally as expensive to take care of oneself at home.
Actually, double the
So, I have my own thought here. You want my own thought right now is I wonder if it's going to push people into not a Medi-Cal solution, because in-home supportive services can only pay for so much at home. People don't have long-term care insurance. Maybe it'll push families together. They may not like it so much, but maybe it'll mirror other cultures, right? If people deal with this, and other cultures, people all live at home, and maybe people who just manage with the ADUs, with people generation.
Well, if the money maybe through waivers could be used for some things like
waiver, but they can, but there's not enough money to go around.
It's
not enough. It's just not enough.
So there's actually a problem with that approach.
Yeah.
It goes back to what I said originally. And we're seeing this around the world in cultures where this does exist and multiple people live, or on Indian reservations where we see this. Everyone lives together, but the younger people are going out to work and coming home, bringing the virus in, and then they're going to kill grandma. So you got to be very careful. And
you have to be careful on that front. You have to,
Right. Can I segue back to one thing, though, which is medical care? How safe is it right now for people to go get medical care? And let's say you're in a situation where you're protecting your nursing home residents. I guess they're getting medical care there mostly, but there's certain services they can't get. Assisted living, they have to go out. How do we balance that? And there's another question. You can take the other one.
Yeah, look, there are always issues with socialization, whether it be at home, whether it be in assisted living facilities. This is always the balance. On the issue of medical care, so I'm a dyed-in-the-wool geriatrician, which means I'm a therapeutic nihilist. I have discontinued more medications in my career than I've started, okay? I believe that when I look at my 100-year-olds over the years and I ask them, how did you get to be 100? The number one answer is I stay away from doctors. Okay, so there's very little.
Like the Civil War.
No.
Right?
What did you say, Terry? There what?
Like historically, what did you, go to a doctor in the 1700s, with a surgeon? Is that a good idea?
And to that point, I actually think that on balance for older adults, not younger adults, but for older adults, I'm not sure that staying at home and staying away from the doctor has been a bad thing. Okay. Now, there are exceptions to that. People with chronic illnesses that have reasons to see, but we've been using telemedicine and we've learned what we can do with that. You know, is it bad that people aren't going to their orthopedic surgeon to get unneeded procedures done on them? Probably not. You know, so is it bad that people aren't going to the cardiologist to get unneeded procedures? Probably not. Now, you know, so I'm absolutely intrigued that while we're seeing a significant increase in deaths in older adults from COVID, I wouldn't be surprised that we might actually have seen a decrease in deaths from not going to the doctor. But that's
interesting.
That's my.
Is that interesting?
Yeah.
That's interesting. Okay, wait a minute. I need to. Anyway, I think we're. Does anyone else have? Oh, I think there's another question. I'm not seeing more questions. Oh, we have something about whether it's safe to go to a restaurant. Let's talk about restaurants, movies, barbers.
So my kids owned a restaurant until about a year and a half ago after the fires in Thousand Oaks. So I reinvested in. So I'm theoretically a former restaurant owner.
I just have to step away for 1 minute.
Number one, I'm not going to a restaurant for the foreseeable future. I cannot see myself going to a restaurant for at least the next year or longer. I don't think the restaurant industry is going to look the same in the future. I think, by the way, restaurants, I don't know how restaurants survive anyway, okay? Honestly, I think for most
they usually don't.
Oh, wait, we had dentists, teeth cleaning.
Only 1 or 2 of 10 restaurants survive,
right.
And there's a good reason. And honestly, I think for most restaurant owners, it's a tax deduction. Okay, so that said, I think the restaurant industry is going to be fundamentally changed. I think much of our society is going to be fundamentally changed. Though, you know, on that note, I read over the weekend, Japan still only has a 2.6% unemployment rate. They are not a socialist society, but they figured out how to deal with COVID. Completely other discussion. It's not medical. Is the question is, you know, what is the lesson for our country as it comes to COVID? And I hope we're going to find out.
Oh, that would be good. That would be good.
That would be good.
By the way, someone just asked about another. This will be.
Oh, good.
Dental care. And is there ever going to be dental care again? Can you ever get? You know.
No, dentists. Yes, you have. You know, look, that's my dread. Is needing a filling or a crown or something like that, breaking it. I've had a few teeth break over the years. Right now, it's the last time I want to have that. But I think dentists are doing everything they can. So that's all you can do, is do everything you can.
Speaking for my dentist, I was pretty impressed with how careful they were.
Fascinating.
Right. This has been a terrific,
professionally and otherwise.
This has been a terrific program. We really thank you for your time and your thoughts. It was very, very well done. And I'm sure everybody appreciated it. And you've given us a lot to think about. What I'd like to do is, and I'll do my part in this as well, is I'll post a resource list, and maybe you can give me information that we can send out to people if there are any recommendations or people you think they should call or how they can participate. I think the more social media, the more people talk about this, it's the only way things are going to get done.
No,
Thank you.
I agree.
That's it.
Thank you guys for giving me the opportunity. You take care.
Thanks very much.
Bye, everybody.
Bye.